While this lecture is called Normocytic Anemia, it's really going to be a review of the hemolytic diseases. We're going to talk a little bit about the other causes of normocytic anemia, but then spend a lot of time going through the high-yield topics in hemolysis. So how do we get here? We had signs and symptoms of anemia, or we just checked the CBC. The hemoglobin was low, and we reflexively looked at the MCV. And for this discussion, it is normal, so we have a normocytic anemia. Now we learned in the overview lecture that normocytic anemias are usually destruction. But we know also that that's not necessarily true because malignancy and chronic kidney disease are production anemias that can be normocytic. What I want you to reflex to is looking for hemolysis. And you do that by getting an LDH, a haptoglobin, and a bilirubin. But I also want you to get a smear. And here's why. If you find the LDH to be elevated, the haptoglobin to be reduced, and the bilirubin to be elevated, this is hemolysis. And this is what we're going to talk about today. I'm going to come back to hemolysis in just a minute. If instead these tests are all negative, chances are it's hemorrhage. And then you practice surgical medicine. You plug the hole and give blood. Now, I do not mean to imply that you are going to diagnose hemorrhage based on lab results. If they are bleeding, they're hemorrhaging. And if you think it's hemorrhage, it's because you see a bunch of blood. Chances are, if they have an anemia and that's it, they're not bleeding, and all these tests are negative, it's probably chronic kidney disease. But the LDH, haptoglobin, and bilirubin tell you that there's hemolysis going on, or not. And so the reason why you get the smear in addition to these is if these tests are negative, but the smear is positive, this is cancer. And what you'll see on the smear is evidence of the marrow malignancy, such as in myelodysplastic syndromes, or you might even see blasts like in leukemia. But hemolysis is where we're going today, and you also get a smear when you think hemolysis, because certain diseases have characteristic smear findings which can really help you narrow down the diagnosis. Sickle cell disease, not surprisingly, will have sickled cells. G6 PD deficiency will have bite cells and Heinz bodies. Hereditary spherocytosis has spherocytes, but unfortunately so does autoimmune hemolytic anemia, and so you can't really use spherocytes to make your diagnosis. And paroxysmal nocturnal hemoglobinuria does not have a characteristic finding. These are the diseases we're going to talk about, starting with sickle cell. Sickle cell is by far more complicated than this. There's an entire pediatric lecture dedicated to it because it's a pediatric disease. What I'm going to cover for you here is what you need to know about management of sickle cell patients as adults. So the pathogenesis of sickle cell is that the cells sickle. And the cells sickle because of hemoglobin SS. This is autosomal recessive and happens to have a predilection in African American communities. Two bad genes get you sickling cells. And so the patient is going to present as an adult with the vaso-occlusive crisis. That is pain. What happens normally is that the donut-shaped red blood cell can squeeze through capillaries. But under periods of acidosis, hypoxemia, or dehydration, these cells sickle. And they cannot fit through the capillary. And this can do one of two things. Either the back pressure causes hemolysis, and we see the hemolysis, or the capillary becomes obstructed and the thing distal to that dies, gets ischemic, and ischemic tissue hurts. So look for the vaso-occlusive crisis, the patient in a lot of pain. But some of the emergencies you need to be able to recognize are the acute chest, which looks like an MI with florid CHF exacerbation. The acute brain, you can imagine ischemia in the brain is going to lead to stroke-like symptoms. And for males, priapism. The diagnosis way back when they were kids, was made with an hemoglobin electrophoresis. The best test is hemoglobin electrophoresis. But you only need to do that one time. Once they have sickle cell disease, you don't need to do that anymore. And even on their first presentation, chances are the first test you did was a smear, and what you saw was sickled cells. Each time they present with a crisis, you look at the smear to see if there's sickled cells. If there are no sickled cells, they're not in a crisis. If there are sickled cells, they are in a crisis. But you do not need to repeat the hemoglobin electrophoresis. It's a one-time thing and is usually done as a child. The treatment of these patients chronically is with hydroxyurea. This induces the formation of hemoglobin F. Your normal hemoglobin is A1. That is a combination of 2 alphas and 2 betas. The beta gene has the bad sickling gene. So if you can replace alpha 2 beta 2 with something else, there's a reduced chance of sickling. And that's what hydroxyurea does. It makes the fetal hemoglobin. In the acute setting, though, because sickling is caused by acidosis, hypoxemia, and dehydration, you need to give these patients intravenous fluids, oxygen supplementation, and pain control because it hurts. And then treat whatever the underlying condition is, for example, often brought on by infections. But every once in a while, you'll need to do the exchange transfusion, where you take out their bad blood and put in good blood. You do this in the setting of acute chest, acute brain, and priapism. Of course, you may do regular transfusions, but you generally want to avoid that because they will become iron overloaded. Most sicklers have a baseline hemoglobin of 7 to 8, and you generally try not to transfuse based on the number, but on the symptoms instead. And if they do become iron overloaded, just as we talked about in the microcytic lecture with thalassemias, treat iron overload with D-furoxamine. Undo the iron from me. What I want you to realize is there is far more to this disease than I'm letting on in this lecture. What I want you to realize is vaso-occlusive crisis, look for sickled cells, treat with fluid, oxygen, pain control. If you see a stroke, MI, or priapism, exchange transfusion, and iron overload is treated with D-furoxamine. The next hemolytic disease is G6PD deficiency. And this also has a predilection for African Americans. The pathology is G6PD deficiency. So what happens when a cell is rich in G6PD? Some sort of oxidant stress comes on and is simply repelled. And a red blood cell that's deficient in G6PD, and you do not have to know the biochemical pathways, the oxidant stress comes through, destroying the cell. There are 2 variants, and the variant that you should learn is not the one you learn about in basic science. It's the African American man who gets exposed to some sort of medication oxidant stress. The medications that are going to do that are dapsone, which is why all patients with HIV are assessed for G6PD deficiency when they're diagnosed, trimethoprim sulfa, and nitrofurantoin. They get exposed to these medications, they turn yellow, their hemoglobin is low, their bilirubin is elevated. Generally, these patients do not require any intervention at the time of the hemolysis. The one you learned about in basic sciences in response to the fava bean business is the Greek version, where the patients can get a potentially fatal condition by ingestion of fava beans, and they always have a chronic mild hemolysis. The one you should learn is the African American variant, where they get exposed to a medication and they have hemolysis, otherwise they're totally normal. The diagnosis is made first by smear. As we talked about, they'll have Heinz bodies and bite cells. The best test is a G6PD level. But the test is going to try to convince you to get a G6PD level during an attack, or they'll give you a G6PD level that's normal during an attack. Young cells have G6PD. They survived the oxidant stress. So if you check G6PD levels right now, the only cells that died were the ones that were wholly deficient. So G6PD levels are artificially normal during an attack. You want to check a G6PD level 6 to 8 weeks after the attack. Treatment is generally supportive during an attack, and you should avoid the stress. Hereditary spherocytosis is caused by red blood cell membrane protein problems, specifically spectrin, ankyrin, and pallidin. The patients are going to present with hemolysis and spherocytes. That is to say, there's not really a characteristic history that tips you off that they have hereditary spherocytosis. It's generally a laboratory diagnosis. What happens in the spleen, the cells that are normally able to fit through cannot deform because they're not donut-shaped. Now they are spheres. And I'm drawing it like that because that's what it'll look like on a slide. It won't have areas of pallor. The spleen says, hey, you can't fit through me, which means you must be bad. Hemolysis. The diagnosis is first a smear, which will show you spherocytes. But autoimmune hemolytic anemia can also present with spherocytes, so finding spherocytes is insufficient. The best test is osmotic fragility. Confirm the diagnosis with an osmotic fragility test. And the treatment is splenectomy. Splenectomy is not going to change the disease. There's still going to be spheres, but it will prevent the anemia. If you are not going to give them a splenectomy, this causes a chronic hemolysis, and you need to support them with folate and iron so you don't induce a secondary anemia. All right, coming down to the wire here, 2 left. Autoimmune hemolytic anemia comes down to one thing, and that's the Coombs test. And it will be positive in both conditions. If the Coombs test is positive for IgM, it is cold autoimmune hemolytic anemia. IgM, associations with mycoplasma, and mono. Cold autoimmune hemolytic anemia causes hemolytic anemia in extremities when it's cold. So you just avoid the cold and it's not a problem. If the Coombs test is positive for IgG, you have warm autoimmune hemolytic anemia, normally associated with autoimmune disease and cancer. Well, you can't avoid warmth, so this one's harder to manage. You generally want to fix the underlying condition, but that's really hard to do. So you're going to use steroids. If steroids fail, you can use rituximab. or you can try splenectomy. Remember that autoimmune hemolytic anemia can present with spherocytes. Positive Coombs, spherocytes, autoimmune hemolytic anemia. Spherocytes, negative Coombs, hereditary spherocytosis. And lastly, paroxysmal nocturnal hemoglobinuria. The path to this is the deficiency of the PIGA gene. And what happens is that normally complement comes around and tries to affix to a cell, but good cells repel it no problem. In paroxysmal nocturnal hemoglobinuria, there's an increased risk because of this anchoring protein that's absent that the complement will fix, the MAC attack complex will form, and the cell will be lysed. The patient presents with paroxysmal nocturnal hemoglobinuria. Why is that? It's paroxysmal because these patients only have an increased risk of complement fixation. They have to cross a certain threshold, and that threshold is not always crossed. It's nocturnal because when you sleep, you don't breathe as often or as deeply, and so you generate hypoxemia and acidosis, both conditions which increase complement fixation. The hemoglobinuria part actually has nothing to do with hemoglobin in your urine. It has to do with hemolysis and bilirubin being elevated, so it looks like you're peeing blood because your urine is dark. The boards like this question not because of the history, but because of the diagnosis and the therapy. The diagnosis is made with flow cytometry. And you'll see a monoclonal expansion of CD55 negative cells. The treatment is usually supportive. That is, nothing need be done. But in refractory or severe cases, you can use eculizumab. And because it's got a crazy sounding name, it becomes a board favorite. Okay, let me take a step back, highlight the things you have to know from each of these diseases. Paroxysmal nocturnal hemoglobinuria, flow cytometry, CD55 negative, eculizumab. Autoimmune hemolytic anemia, Coombs test. IgM, cold, avoid cold. IgG, warm, give steroids. Hereditary spherocytosis, find smears, do osmotic fragility test. Don't just take out the spleen because you see spherocytes. G6PD deficiency, Heinz bodies, bite cells, but get the G6PD level 6 to 8 weeks later. Sickle cell disease, acute crises, sickled cells on the smear, chronic management with hydroxyurea, acute management with fluid oxygen and pain control. If you've got an acute chest or acute brain, do an exchange transfusion and treat iron overload with defuroxamine. And that is normocytic anemia.